vitamin D and COVID-19. Let us go to the topic. As I have already told, vitamin D represents one of the major driving factors for the development of life on Earth and for human evolution. While up to 10 to 20% of our requirements in vitamin D can be obtained from the diet, approximately 80 to 90% of all needed vitamin D has to be photosynthesized in the skin through the action of ultraviolet B rays of the sun. Is there any difference between the vitamin supplements, vitamins from the food, and vitamin that is being produced from the sun? Definitely there are some differences. This we will see in detail later on. As we all know, bioactive vitamin D or calcitriol is a steroid hormone. It's a pro-hormone actually, that has long been known for its important role in regulating body levels of calcium and phosphorus, and of course, in the mineralization of bone. More recently, it has become very clear that receptors for vitamin D are present in almost all the cells of our body. And this vitamin hormone has biologic effects that extend far beyond the control of mineral metabolism. After today's talk, that is part 1 of the 3 series webinar, COVID-19 and vitamin D, we will have our second talk on vitamin D in health on next Friday, that is 21st August, same time, and part 3 that is on vitamin D in disease and dose recommendations on Friday 28th. Next week's program, it will be chaired by our IMA leaders, and the week after that it will be chaired by one of the doyens of in India, the vitamin D doyens. I will share with you the names after confirming with them about their acceptance to be here. So the main query, as I have told you, that I have faced after announcing the webinar was, why such a long series on vitamin D? I think I have already answered that. Please, one earnest request is, please do attend all the 3 sessions. Do post your queries in the chat boxes. Time permitting, most of them will be covered after this talk. The rest will be covered during an additional video on frequently asked questions on vitamin D in health and disease after the 3 talks are over. Now, let us examine the relationship between vitamin D and COVID in today's first part of the series. It is now more than 100 years since the outbreak of the 1918 influenza pandemic. Now we are facing another pandemic of equal gravity, if not more. Many studies have reported that people who died of COVID-19 tended to have low levels of vitamin D. Of course, majority of those people had other comorbidities as well. Age and health status, not just vitamin D levels, may have made these people more vulnerable to poor health outcomes after being infected with this COVID-19. There have been dozens of studies during the last decade pointing towards the link between vitamin D deficiency and vulnerability to respiratory tract infections. It was but natural that this relationship was applied to COVID-19 infection too, lungs being its main target organ. There have been some reviews which were quick to point out that these are mainly observational studies and not randomized, double-blind, controlled clinical studies. They lack standard systematic reviews or meta-analysis of RCTs. This was the main points against the studies that pointed towards a link between vitamin D and COVID-19. Now, a fundamental question arises here. How do we pick out a single nutrient and prove or disprove its connection with the disease? It's a straightforward case when you refurbish vitamin D in a case of rickets and the deficiency is cured. There is no doubt there. But imagine when this vitamin or hormone is a facilitator of a particular cellular function, as we will see in part 2 of this series next week. Remember that this particular cellular function is regulated or controlled by umpteen number of other factors, including other vitamins, hormones, enzymes, coenzymes, minerals, genes, age, environment, fluid and electrolyte balance, neural and vascular supplies, etc., etc. So many factors affect the causation of any disease or ill health. When deficiency or excess of any of the above parameters can affect the real outcome, the ultimate outcome, how do we pick a single factor out of all these and prove or disprove its positive or negative effects? And how can we say that this or that factor do or do not affect the course of this disease? Confusing? Let me try to explain in simple terms. Imagine a machine working on electricity. If it runs on low voltage for a prolonged period of time, the wear and tear will produce a breakdown soon. That's sure. We know that. Once the machine parts are burnt or broken down, will it again work properly if we provide electricity in proper voltage? No. Then, at that point, can we infer that electricity has got no role in the proper functioning of the machine? See, this is the dilemma of our evidence-based medicine. We all, as medical professionals, as the men of science, we all vouch for evidence-based medicine. But remember, evidence-based medicine is not just studies. When studies prove something against the natural physiology or biochemistry of our body, then we have to look deeper. When we cannot find evidence, that does not mean that the evidence does not exist. We can only say that at present there is no solid evidence to prove or disprove such and such hypothesis. This paradoxical dilemma of evidence-based medicine came out as a stark, if not shocking, realization for our scientific community after this pandemic started. I need not elaborate on this. I think you all know what I mean. What do we do in such a situation? The answer is simple. Go to your classes, as one of my close friend, Dr. George Joseph, used to say. Go to your classes, yes. Let us go back to basics. This is exactly what we will be doing next week and the week after during the second part of the series on vitamin D. Please do not miss it. Now, with all the controversies and keeping the above dilemma in mind, let us closely examine some studies that have come out linking vitamin D deficiency and severe COVID-19 illnesses. We will also examine the major reports which states that there is no evidence for such a link. As we are aware, the immune response induced by SARS-CoV-2 infection is biphasic, two-phased. During the incubation and non-severe stages in this area, non-specific innate immune response is essentially required to eliminate the virus and to break the disease progression to these severe stages. So we know that this depends upon the general health and immune status of the host. When the innate immune system fails to contain the virus will propagate and the host immune response will go into a hyperactive, hyper-responsive state. This, we all know, is known as cytokine storm, which causes massive destruction of the affected tissues, especially in organs that have high ACE2 expression. We'll see that soon, such as lungs, intestines, and kidneys. It is clear now that along with viral virulence or mutation, as I told earlier, the host immune response plays an important role in the COVID-19 induced morbidity and mortality. It follows naturally that all factors influencing and regulating our immune response to the COVID-19 virus will have to be considered while considering preventive and therapeutic strategies to bind down the pandemic. This is where the role of vitamin D comes. Not only vitamin D, other nutrients. Needless to say, vitamin D is not a standalone nutrient, as I have told already. It works in coordination with other vitamins and minerals. We will examine this as well in subsequent lectures. Now we go to a few studies. Let us examine. This came in last decade, linking vitamin D and specifically respiratory infections. An important review in 2015 by Dancer et al. Noted that vitamin D deficiency may actually be considered a risk factor for sepsis and inflammatory disorders, as one of the major roles of vitamin D is to lower exacerbation risk associated with inflammation. They also cautioned that vitamin D deficiency contributes directly to the cytokine storm and acute respiratory distress syndrome. This was in 2015. This was corroborated in the same year by Rachel et al., who found that vitamin D deficiency is common in people who develop ARDS, acute respiratory distress syndrome. This deficiency of vitamin D appears to contribute to the development of the condition, that is the ARDS. And they recommended that approaches to correct vitamin D deficiency in patients at risk of ARDS should be developed soon, 2015. In 2017, a large study in British Medical Journal, which analyzed 25 eligible RCTs with a total of 11,321 participants aged from birth till 95 years. They concluded that vitamin D supplementation was safe and it protected against acute respiratory tract infection overall. Patients who were very vitamin D deficient and those not receiving bolus doses experience the most benefit. This is important. We will see later why it is so. Nearer in May 2020, just 2-3 months back, in a perspective study in European Journal of Clinical Nutrition, Mariam Ebadi et al. Noted that patients with mild to severe vitamin D deficiency are high-risk groups to get severe COVID-19 illnesses. Given the high prevalence of vitamin D deficiency, and in order to rapidly, safely, and significantly raise serum concentrations, they recommended high-dose vitamin D intervention with potential benefit in decreasing the risk of COVID-19 severity and mortality. And they say, of course, it is a safe and non-invasive treatment. But we have to be careful here about the upper dose of toxicity that can cause toxicity. Now, this is another ongoing study, COVID study in UK. Adrian Martineau, the lead author of the 2017 meta-analysis, has joined with colleagues from universities around the UK to launch this study. It investigates how diet and lifestyle factors might influence transmission of SARS-CoV-2, severity of COVID-19 symptoms, speed of recovery, and any long-term effects. They aim to recruit at least 12,000 people and to obtain interim results by the summer. Despite his enthusiasm for the study, Martineau himself is a little pragmatic about the study. At best, vitamin D deficiency will only be one of the main factors involved in determining outcome of COVID-19. But it's a problem that could be corrected safely and cheaply. There is no downside to speak of and good reason to think there might be a benefit. Many healthcare professionals are still under the impression that there are not many studies linking COVID-19 and vitamin D. My review of the literature regarding COVID-19 and vitamin D during the last 3 months tells a different story. There are dozens of studies in various stages of completion reported from around the world, all types: population studies, retrospective studies, observational studies, meta-analysis, ongoing clinical trials and reviews. We will just browse through a few of them. This study, low plasma vitamin D level is associated with increased risk of COVID-19 infection. It's an Israeli population-based study. Was published in July in peer-reviewed PHEBS journal. Researchers at Tel Aviv University studied 782 COVID-19 and 7,025 non-COVID-19 cases. They found that the mean vitamin D levels were significantly lower in COVID-19 than non-COVID-19 cases. More importantly, low vitamin D levels increase the odds of hospitalization due to COVID-19 by 95%, very significant number, after adjusting for demographics and comorbidities confounders. Low plasma 25 hydroxy D vitamin D levels appears to be an independent risk factor that they have opined. In another preprint paper, this from Indonesia, they studied 780 cases of COVID-19, of which 380 died and 400 survived. Tracing back their medical records, looking for blood levels of vitamin D, any disease, comorbidity, etc., they discovered that in dead cases, almost 46.7% had vitamin D deficiency, 49% had vitamin D insufficiency, and only the remaining 4.2% had normal vitamin D levels. In survived cases, the data, the statistics has reversed. Almost 93% had normal vitamin D levels in the survived cases. Another preliminary study from, it is from Philippines this time. They classified COVID-19 in order of severity into mild, ordinary, severe, and critical. They found that 55 patients had normal vitamin D levels, of which 85.5% had mild disease, 7.3% had ordinary, 3.6% each had severe and critical disease. This is, see the higher number of mild diseases in normal vitamin D levels. Now with vitamin D deficiency, 80 patients, they had higher levels of almost 28.8% had severe and 26.3% had critical, and 43.8% had ordinary, that is the normal flu. But see, 77 patients who had vitamin D deficiency, almost 83% of them, 73% of them had either severe or critical illness. This is very significant. This is the retrospective study from Philippines. In another retrospective study, this time it is peer-reviewed and published in Clinical Endocrinology, which was published on 3rd July from UK. The researchers measured serum vitamin D levels in 134 people tested positive for COVID-19 in the UK. They found that only 19%, that is 8 out of 42 patients admitted to ICU had normal vitamin D levels. And this number is 39.1%, that is 36 out of 92 in those with non-ICU level severity. This is another important study. Dr. P.C. Illy, consultant and urological surgeon at Queen Elizabeth Hospital in Norfolk, led a study examining the relationship between average levels of blood vitamin D and COVID-19 death rate in 20 European countries. Vitamin D levels are severely low in the aging population, especially in Spain, Italy, and Switzerland. This is also the most vulnerable group of the population in relationship to COVID-19, they wrote. Vitamin D has already been shown by meta-analysis of studies to protect against acute respiratory infections, and it was shown to be safe. So they believe that it can be advised that vitamin D supplementation has to be given to protect against COVID-19 infections. In a similar study regarding the role of vitamin D in the prevention of COVID-19 infection, progression, and severity. This was published in the Journal of Infection and Public Health on 20th June 2020. Researchers compared the incidence and mortality of COVID cases per million population in April and May in 20 European countries. The values are in nanomole per liter because they use nanomole per liter in those areas. We use nanogram per ml. Just to 1 nanogram per ml is equal to 2.5 nanomole per liter. We'll just go through this. See, this is the normal levels. Before we go on to the next discussion, you should know what are the normal levels, what are the optimal level, what is sufficiency, what is insufficiency, what is deficiency, and what is severe deficiency. This is the optimum level, 40 to 50. From 30 to 50 it comes. 30 is the cutoff rate for 30 nanogram per ml. If it is nanomole, it is 75 nanomole per liter. So 75 nanomole per liter or 30 nanogram per ml is the sufficiency cutoff. This sufficiency cutoff was previously put, it was decided on the basis of the vitamin D requirement for the normal calcium and mineral metabolism and bone mineralization. So now we have come to a state where it has been discovered that vitamin D receptors are there in each and every cell of the body, and actually this 30 nanogram per ml may not be sufficient. We'll see in detail in the next talk about this. So hence, most of the authors who have studied in detail about vitamin D advise that we should aim for something optimal levels between 40 to 50. Some say 60, but there are some studies pointing towards a few side effects above 50. So we will keep the optimum between 30 to 50. And from 20 to 30 nanogram per ml, it is insufficiency. And from 10 to 20, it is real deficiency, and severe deficiency below 10 nanogram per ml. So this is the normal levels. Most people say, most doctors even say that most of the people are deficient, then why do you want to check test? Just give them normal maintenance doses. Actually, I don't agree with that, because if the people are in the severe deficiency state or the deficiency state, they need much higher doses. If they are in the sufficiency or just insufficient state, then they need normal doses. If they are in the optimal level, they need only a maintenance dose. So it is very important to check for the levels first and then treat accordingly. This is another thing just for you to remember. The normal 20 to 50 is the insufficiency level, and 30 to 75 is the sufficiency level. 1 nanogram into 2.5 is 1 nanomole. Now, this is the study that we have seen before. I was telling about this thing. This is the nanomole. When you see this study, a very interesting observations come up. This is done in 20 European countries. See, we can clearly see that when vitamin D levels improved, the infectivity, this is the infectivity model, it is decreasing, as well as the mortality rate also is decreasing as the vitamin D levels increase. In another observational study, researchers analyzed patient data from 10 countries this time. They noted that patients with severe vitamin D deficiency are twice as likely to experience major complications after COVID-19 infection. They concluded that vitamin D strengthens innate immunity and prevents overactive immune response in COVID-19. Very important. Now another meta-analysis, this time it is meta-analysis. There are dozens of meta-analysis connecting vitamin D deficiency and respiratory tract infections. More than 2 dozens I have already gone through. And this all suggests that vitamin D supplementation appears to be protective against respiratory tract infections. This has come since last 10 years or so. This protection is more apparent. They have also noted that the protection is more apparent in patients with lower levels of vitamin D than in normal. If patients with normal vitamin D level is given extra vitamin D, it does not have that much effect. It does not protect against further infection. But patients definitely, there is, the studies have proven that serum concentrations of vitamin D is inversely associated with pro-inflammatory cytokines, IL-6, that is increased C-reactive protein, and increased risk of pneumonia, ARDS, and even diabetes and heart failure. There are so many studies there. We will examine those in the third session of this talk. Now, a July meta-analysis published in the Journal of Medical Virology of 8 studies, including preprints, comprising of 1,368 COVID-19 patients, found a significant association between vitamin D insufficiency and severe COVID-19. Patients with poor prognosis had significantly lower serum levels of vitamin D compared to those with good prognosis. Serum vitamin D levels could be implicated in the COVID-19 prognosis. So diagnosis of vitamin D deficiency could be a helpful adjunct in assessing patients' potential of developing severe COVID-19. So this is essential. We should check all our patients of COVID-19 for their vitamin D levels to predict, because this, as Professor Shashidharan rightly pointed out, it not only points towards vitamin D deficiency, it points towards a general nutritional deficiency. All other factors are also working together here to predispose the patient to severe infections. Now, this is the ongoing clinical trial. The University Hospital Angers in France is currently conducting a phase 3 clinical trial that aims to enroll 260 elderly, about 70 years or above, diagnosed with COVID-19 within 48 hours of the diagnosis. Exclusion criteria entailed anyone who has been taking vitamin D supplements or with medical conditions that cause vitamin D intolerance. They wanted to see only the how vitamin D actually affected the course of the disease. The intervention is with the high dose vitamin D at 400,000 international units or 50,000 international units daily or 14 days. The main outcome will be the death rate from COVID-19. The clinical trial is expected to be completed sometime in the coming months. For about half the population, this is the evidence supporting role of vitamin D in reducing risk of COVID-19. A review of many studies, and they also have reiterated that studies find that vitamin D deficiency is an independent risk factor for COVID-19 death, and providing with a high dose vitamin D gave real good prognostic outcome. Now, there are other reviews also which points out that several other micronutrients may also be deficient along with vitamin D. So just supplementing with vitamin D may not be sufficient. You have to supplement along with the vitamin D, as we will see later on. Vitamin D does not work alone. It, at the molecular level, it works along with vitamin A, vitamin C, magnesium, selenium, zinc, and some other potassium too, K2 also. So there are so many other factors that can work together for a optimum cellular functions. This is another review with the circumstantial evidences pointing towards a very strong link between vitamin D and COVID-19 link. I'm not going into details of it. There are so many you can search. Now, we will go a little deeper. How vitamin D, we have seen the studies that link vitamin D and COVID-19. We will see what are the mechanism of action of vitamin D in this thing. How does vitamin D influence COVID-19 infection outcome? As you can see, a little pathophysiology is required, not only the clinical studies. We should go back to our basics now. COVID-19, as we all know, is caused by the severe acute respiratory syndrome coronavirus 2, which enters human cells by binding the spike protein S to the angiotensin converting enzyme 2, that is the ACE2 receptors. This is why a protease-dependent mechanism. These ACE2 receptors are present in the epithelium of lungs, which is the site of SARS-CoV-2 entry mainly, as well as the proximal tubule of kidney, myocardium, blood vessels, ileum, esophagus, and bladder, and of course from the whole of the respiratory tract, starting from the nose. Now, you all know about Renin-Angiotensin system. The viewers who are the medical professionals who are here, I need not go into details. We all know that the Renin-Angiotensin system, along with aldosterone, is the complex network that plays a major role in maintaining our blood pressure, our fluid and salt balance, and also it is one of the receptors on our cell surfaces which allows the entry of the COVID-19 virus. The main thing is, during the metabolic pathway, the ACE enzyme converts angiotensin 1 to angiotensin 2, which is inflammatory in nature, and its levels are linked to disease severity in many infections, especially the respiratory infections, including COVID-19. The main thing is angiotensin 2, instead of angiotensin 2, which is a pro-inflammatory, pro-fibrotic, and pro-proliferative agent which causes vasoconstriction. It is converted by ACE2 to angiotensin 17A, that is A17, which is anti-inflammatory, anti-fibrotic, and causes vasodilation. So ACE2 is the good enzyme there, and ACE is the bad enzyme, and angiotensin 2 is the problem creator. So what does COVID-2 do? COVID-2 connects, it attaches its spike protein, attaches to ACE2 and inactivates ACE2. So ACE2 cannot convert angiotensin 2 to angiotensin 17, and there is no anti-inflammatory action. So it produces severe inflammatory reaction predisposing to cytokine storm. This has been studied in detail. We'll go into details of this in the second talk. Now, where does vitamin D come? The role of vitamin D. SARS-CoV-2, as we have already seen, binds to the ACE2 of alveolar cells and disturbs the ratio of ACE2-ACE activity. This in turn increases the ACE2 activity and results in more production of angiotensin 2, as we have already seen, causing pulmonary vasoconstriction to precipitate severe COVID-19, that is ARDS. Vitamin D induces ACE2 expression, which limits the formation of angiotensin 2 via ACE and reduces the lung injury. This is where vitamin D comes into action. It inhibits the ACE and it induces the ACE2. Besides, vitamin D also acts on renin and inhibits its activity, which further contributes to the reduction of angiotensin 2. Therefore, we can infer from this that vitamin D supplementation may have a protective role against COVID-19. So this is the inference that they have come to in the elementary and pharmacology and therapeutics volume. This was in May 2020. Now, about the immune actions of vitamin D, a little about that. We'll go into detail next time. This is just a preview of the effects of vitamin D on our immune system. In a nutshell, vitamin D acts on our innate immune system through a number of actions. It has got stimulatory effects on the immune cells like the macrophages and phagocytes during the initial attack of invading pathogens. Now, one of the main mechanisms is through the induction of antimicrobial peptides, that is cathelicidins and defensins, which kills the viruses, bacteria, and other pathogens. So this for the cathelicidins and defensins to be induced, we require vitamin D in optimal level in each and every cell. This is how, this is the molecular mechanism of action of vitamin D in innate immunity. The recent discovery that vitamin D induces antimicrobial peptide gene expression explains in part the antibiotic effect of vitamin D and has greatly renewed interest in the ability of vitamin D to improve immune function. Subsequent work indicates that this regulation is biologically important for the response of innate immune system to wounds and infection, and that deficiency may lead to suboptimal response towards bacterial and viral infections. We can see the pathogen getting detected in the cell surface by the TLR, that is the toll-like receptors, which attaches to the pathogen and and the pathogen enters. This is part of the ACE2 receptor also. And once TLR comes, and this is the second part where the vitamin D receptor in the cell and the enzyme that hydrolyzes inactive vitamin D to the active vitamin D is activated. Once it is activated, this combination of vitamin D receptor as well as the hydrolyzing enzyme, this activates the cathelicidin gene. This is the cathelicidin gene is activated here, and the protein, this is the protein synthesis is genetically stimulated. Actually, vitamin D is a genetic decoder. We'll see in detail next time. I'm not going into details this because it will take a long time and it will be a repetition. So this is how the vitamin D receptor, which is attached with the enzyme and the activated vitamin D, stimulates the cathelicidin and defensin induction, which enters the macrophages and kills the viruses. So this is what is the phagocytes engulfing the virus as it enters, and this mechanism stimulates, and then the virus is killed. So this is the induction of innate immunity. So imagine when we don't have sufficient vitamin D in our body, we are deficient in vitamin D. How is this going to happen? If this is not happening, what is going to happen? We'll see in the next slide. There is also other studies. In addition to the angiotensin renin system, the expression of inflammatory cytokines are inhibited by vitamin D, and its insufficiency was associated with overexpression of Th1 cytokines, which causes inflammation. This came as early as 2009, and recently in Chicago, more than half of vitamin D cases and around 70% of COVID-19 deaths were observed in African American individuals who are at the greater risk of vitamin D deficiency. This is the what we have seen in our about the very interesting study which predicted vitamin D values in association with raised C-reactive protein, which is a surrogate marker for overreactive immune response or cytokine storm in COVID-19. Retrospective data and indirect evidence show a possible role of vitamin D in reducing complications attributed to unregulated inflammation and cytokine storm. This is how the cytokine storm can be stimulated by vitamin D. In vitamin D deficiency, there is decreased innate immune response. The virus is not killed, and the virus multiplies fast, there is increased viral load. When there is increased viral load, there is increased immune response, hyperresponsiveness, which results in cytokine storm. So if it had the innate immunity had actually controlled the production or the increase in viral load, if it had reduced the viral load, this thing would not have happened. And there are other mechanisms where vitamin D inhibits cytokine expressions directly as well, and also by its inhibition of the Renin-Angiotensin system also, it can affect the cytokine storm. See how important is this? Without knowing, without studying about this, we were all under the impression that vitamin D is just another vitamin. Please rethink about it. Other studies, I am not going to details, most of which we have already seen. This is a very interesting study where they have connected the severity of the increased incidence and case fatality rate of COVID-19 infection with the vitamin D deficiency. This is with the comorbidities. In addition to the immunological effects, they also took into account the relationship of vitamin deficiency in comorbid conditions and gave a few recommendations. Recommendations is slightly on the higher side. They say that people at risk of influenza and or COVID-19 should consider taking 10,000 international units per day of vitamin D3 actually for a few weeks, approximately 1 month, to rapidly raise their active vitamin D concentrations, followed by a maintenance dose of 5,000 international units per day. The goal should be to raise the vitamin D concentrations above 40 to 60, not above, it should be between 40 to 60, the optimum levels that we have seen. For treatment of people who become infected with COVID-19, higher vitamin D3 doses might be useful, though this is a controversial point. Higher may not be always better. Randomized controlled trials and large population studies should be conducted to evaluate these recommendations. That also they are told in the end, because we cannot be sure about how it acts until we study lots of patients and give them high dose oral vitamin D, especially to the risky group as well as the people before going into the severe stages. This is another study with a loading dose of 200,000 to 300,000 international units to reduce the risk and severity of vitamin D. The results are awaited. The question naturally arises, will such high doses cause toxicity? In general, to cause adverse effects from orally administered vitamin D, one needs to take daily doses higher than 25,000 international units for many months, or take 1 million international units daily for a few days. This has been shown because in a few cases, even infants have been given wrongly by their mothers high doses daily instead of the recommended doses, and they went into hypercalciuria and other side effects of vitamin D toxicity. So these studies, the amount of vitamin D that is required to cause is very high. Usually, we have been using vitamin D for the last 20 years or so. I have not come across any cases of vitamin D toxicity so far, though we deal with so many cases of vitamin D deficiency. From a disease prevention strategy point of view, they say the most cost-effective approach would be the prophylactic administration of high-dose vitamin D to the entire community at risk before the coronavirus appears in that locality. Such short-term administration of vitamin D is safe. This was their, after the review of journals, this was their inference. But a word of caution here, as I told, we need more studies about high-dose therapy. A few case reports are there where hypercalciuria has taken place above 50 nanogram per ml. And there are also a few studies mentioning inverse relationship of low and high vitamin D levels to comorbidities like heart diseases and multiple sclerosis and hypertension. So even diabetes. So we have to be careful here. Better not go over the fence with over enthusiasm. Be careful. It is better to see that our patients have got vitamin D in an optimum level than in a deficient level. We will examine this in detail in our next lectures again. This is the individual risk management strategy of SARS-CoV-2 in a nutshell. There is, of course, we know the protective and preventive measures like personal hygiene, hand washing, the physical distancing. I prefer physical distancing rather than social distancing. Social distancing has got other connotations. That was seen in India recently when our the Pravasis, the expatriates went back and they were really kept away by the society. It is not social distancing what we need. What we need is physical distancing and face masks, of course. Now, the most important thing that we have to take care is the host metabolic status. Considering all the in addition to the metabolic condition management, the disease management that is going on very well in our hospitals with the frontline barriers. We have to take care of the microbiomes in the gut, as well as the diet and nutrition, lifestyle and environmental protection for the whole society. As Professor Shashidharan rightly told, it is necessary that we approach the problem of not only COVID-19, but the whole spectrum of infections and lifestyle diseases in a broad manner considering all these factors together. We should not be taken to ransom, held at ransom by any other virus in the future. So let us take all the precautions. Let us advise our patients on the healthy lifestyle and healthy nutritional status, including normal vitamin D levels. So these are the inferences that we have got. Serum vitamin D level in the body could account for clinical outcomes of patients infected with COVID-19. An increase in serum vitamin D levels in the body could either improve clinical outcomes or mitigate worst situations. On the other hand, a decrease in serum vitamin D levels in the body could worsen clinical outcomes of COVID-19. There are many pointers. We have already seen all these things. I will not go in details. The striking overlap between risk factors for severe COVID-19 and vitamin D deficiency, including obesity, older age, and Black or Asian ethnic origin, points towards vitamin D supplementation as a preventive or therapeutic agent for COVID-19. Vitamin D metabolites have long been known to support innate antiviral effector mechanisms, including induction of antimicrobial peptides and autophagy. Active vitamin D metabolite shows inhibitory effects on human nasal epithelial cells infected with SARS-CoV-2. Vitamin D regulates immunopathological inflammatory responses through mediation through the Renin-Angiotensin system. This, in fact, controls the cytokine storm as well. Now, there are many ecological studies, two of them very important, which have reported inverse correlation between national estimates of vitamin D status and COVID-19 incidence and mortality in European countries. These are all things that we have already told. So to sum up about vitamin D and COVID-19, vitamin D deficiency may only be one of the many factors involved in determining outcome of COVID-19, but it is very important. It is a problem that could be corrected safely and cheaply. This is also important. No need to wait for costly medicines and costly vaccines. We already have a vaccine in our own hands. Just go out in the sun, lead a healthy lifestyle, have a balanced, nutritious diet, and take care of your morbid conditions. That itself is much higher than any preventive measures that we can take against viruses like COVID-19. There is no downside to speak of. This is also important and good reason to think that there may be a benefit. There are many evidences supporting a causal role for vitamin D status, but when studies find this also, we as men of science, we have to also think out of the box also. When studies find an association between two things, it does not mean one thing caused the other one to happen. When we are talking about and studying about vitamin D, we should think about this also. But because there are problems in establishing causality of a disease. There are, as we have already seen, there are many factors, many parameters that affect. There are multiple causations for a disease. It's not a single. And for infective agents, it is okay. Cause postulates only mainly concentrates on the infective agent, not the host response. So these things we have to take care and consider before considering a causative relationship of any agent, including vitamin D, with any disease. But there are many evidences, many pointers pointing towards the link between vitamin D and infections like COVID-19. Now, we have been seeing only the positive side of the picture. There are a few negative reports also. It will not be correct on my part to not to go through those reports also. This report found that no clinical evidence. This is in the CEBM, evidence-based medicine. The clinical evidence-based medicine journal. They found no clinical evidence that vitamin D supplements are beneficial in preventing or treating COVID-19. I don't know what clinical evidence they were looking for, but there is no reported trials on the protective effect of vitamin D for COVID-19. This was May 1st mistake. But they say that observational evidence suggests that low, particularly very low, blood vitamin D concentrations are associated with a higher incidence of the acute respiratory tract infections. Vitamin D3 supplementation, they also say, resulted in a significant reduction in the proportion of patients experiencing at least one ART. Reviews and meta-analysis of randomized clinical trials have found a protective effect of vitamin D3 supplementation taken over weeks to months. So they go on to say that actually vitamin D is useful, but the first two sentences are being highlighted by many of our colleagues to show that there is no clinical evidence that vitamin D supplements are beneficial in preventing or treating COVID-19. We should go through the whole article before judging it. Now, there is another one that came from the National Institute of Health and Care Excellence, UK. They studied they reviewed 5 studies, and they told a bias, a high risk of bias in the studies. None of the studies were intervention studies of vitamin D supplementation. For example, randomized controlled studies. So no data on appropriate doses or adverse events was given. A person's individual risk of vitamin D deficiency may have changed during the COVID-19 pandemic, particularly if they are spending more time indoors. This also they have noted. And they say that people should continue to take their vitamin D supplements, especially in countries like UK, where they got very low sunlight sources during majority of the time during the year. So they should continue to take, but still they say there is no evidence for vitamin D in COVID-19. This is because there are lots of reasons for this. Their suggestion is 10 micrograms of vitamin D a day. 10 microgram means 400 international units, and maximum 100 micrograms, that is 4,000 international units of vitamin D per day. That is the safe limits. If they also caution that the patients take higher therapeutic doses of vitamin D, as has been suggested in the other studies, monitoring is of course recommended. Now, what are the limitations of such reviews? We have already seen that it's only 6 months now. We are running to 7th month of start of the pandemic. Is it time for so many randomized clinical studies to come out? No. What we do in such situations? Do we just push away such an important factor of which has got many effects on the course, on the incidence, course and severity and prognosis of COVID-19, and wait for such studies to come? This is the limitation of such reviews. It is better to be err on the safer side. That is what we should remember as medical professionals. We should be thinking about our patients, their benefit and their welfare, rather than depending upon just reviews of a few studies. This is a question that has really actually troubled me during last 4 or 5 months after the fiasco that happens in Journal of in the Lancet and New England Journal of Medicine, which they had to withdraw 2 articles on studies on hydroxychloroquine, and this cut a very, very sorry figure for our evidence-based medicine. Does it mislead at times? See, this is the thing. If we only study the studies that are given negative aspects, then our review will show only negative aspects. If we study the right studies, the positive studies, our review will show positive aspects. But if all these studies have not taken care of the basic metabolic actions of the vitamin D, now we are talking about it, or any other thing. If they are not taken into account that basic molecular activity of the factor or vitamin or hormone or whatever, or medicine or whatever it is, how can we rely on such reviews on evidence-based medicine? See, we are seeing lots of pro and cons. Many reports, both in the non-medical, in the lay public magazines, as well as in the medical journals, both positive and negative. No evidence that vitamin D. In all these evidences, there comes one saying no evidence, and many of us tend to just point out towards that no evidence articles, but this is not sufficient. Let us think. So I come to the end of today's talk. The question is vitamin D the modern day snake oil? We all know what snake oil is. The cure-all. They will say that this is scientific and we cure everything, we take care of everything, and this is what you require for any disease. Is vitamin D one like that, or is it just an optional supplement? If you are deficient, you can take, or if you are not deficient, you do not take. You need not check for your levels. Only if you fall ill, you check and then you take. All this, is it just an optional supplement, or is it a cellular necessity? This is what we have to consider. This is what we will consider in the next talk, next week, in the same time. We will be on Zoom. I'll share the Zoom link next time and upload the recording on the Facebook page later on. I think that is better, given the inadequacies of our technology. So thanks everyone. Next, let's go to the basic from next week onwards. Now we will we'll take some questions. Any comments?
One question was asked up by Dr. Shyam Joshi, one of our classmates, that can we assay or can we measure how much usually the vitamin D is taken by a 15 to 20-minute exposure or about half an hour exposure? This question was like that.
This will be covered during our next talk, but I think Professor Shashidharan
I can answer that, because
yeah,
one can never do a study on how much vitamin D you get by sunlight exposure, because it depends on several variables. The skin, the pigmentation status of the individual matters. The basic, because the skin cutaneous synthesis will be better only if you get a balanced diet.
yeah.
We do not know how much is the balanced diet that particular person consumes. We do not know how much is the functionality of the liver and kidneys of that particular person, whether he consumes vegetables and fruits in adequately, whether already his liver and kidneys are damaged. All these are neglected when you just take a person to sunlight and then compare. Even the sunlight matters at what time of the day. If the pigmentation matters, the health of the skin matters. So it is never possible to find out how much vitamin D you will get by this much of sunlight exposure. This depends on too many variables. So it is not possible. So there is no point comparing. In fact, evidence-based medicine itself is a failure in finding out etiological aspects of diseases. This is only for drug trials. This is the failure that modern medicine is now facing. We depend on evidence. Actually, it becomes a jargon. You do not know what is right and what is wrong. We ultimately have to depend on our common sense and clinical skill, and then use investigations and evidence very discriminately. That is very important. About this vitamin D and ARDS issue, I have found that I have been studying all those patients who developed ARDS. In fact, vitamin D deficiency was there. It is true we can link it to ACE receptor and all those things. But in addition, all of them had other problems. Like, for example, if they were overweight, even 2 kilogram excess weight is enough to produce in some individuals a non-alcoholic steatohepatitis. Or they may be having underlying liver disease due to other reasons. When you have liver disease, by any reason, they have protein CS deficiency. Protein CS and S are synthesized in the liver. These are natural anticoagulants. The deficiency of that is a reason for the thrombosis. One of the reasons for thrombosis which leads to ARDS. Another reason for thrombosis is those who are deficient in vitamin D are also deficient in B12, folic acid, pyridoxine, or all of them.
Yeah.
And that will lead to hyperhomocystinemia, another thrombotic tendency. And all these together are responsible for the thrombotic tendency in the lungs, which leads to the ARDS. It's not just vitamin D alone. Yes. So once you give vitamin D, it can sometimes modify it towards a favorable end, but you need to find out all the problems by studying the person for diet and lifestyle and modify it. And we have been doing it, and I had advocated that to all my students, whoever I'm in contact with, and none of them is going into ventilator now. Actually, ventilator care has become almost nil, very rare, rarely only happening if you can advocate all these. So we need to correct B12 deficiency, folic acid deficiency, vitamin D deficiency, hydration, reduce weight if possible, if they stay for a longer period, give vitamin D supplements and calcium. All these have to be looked after. It's not just one thing alone.
Yes.
That is what we have to look at.
Thank you, Dr. Shashidharan. That
Thank
was
you,
a
sir.
real wonderful thing. The holistic outlook towards that, as we have already stressed, it is not just vitamin D. It is not a standalone nutrition or nutrient. It has to be considered along with other nutrients as well as lifestyle management. One thing I would like to add is there are a few studies which have found that what they did was they measured the vitamin D before and after the sun exposure. Of course, the other factors are also there. And some of them told that half an hour exposure to sunlight between 10 to 3 p.m. caused a rise of vitamin D levels of equivalent to 20,000 international units has been administered. But this has to be taken with a pinch of salt and pepper, because vitamin D, the level that we, as Dr. Shashidharan told, the level that we measure is 25 hydroxy vitamin D3. that is not the only indicator of vitamin D. Vitamin D being a fat-soluble vitamin, it is it is deposited in the fat. That is why as doctor told, the obese people require more vitamins. They are more prone for vitamin D deficiency. So we are not taking into account the vitamin D that is stored already, and another forms of vitamin D. And vitamin D itself does not act alone. It requires an active vitamin D receptor, the vitamin D binding protein, and of course, the level of the parathormones, the calcium levels. All these things are related, and the other nutrients. Thank you. Any other questions?
Permission of Dr. Patnaik. There is one question: how often vitamin D has to be monitored? One of the speakers can answer that.
See, monitoring vitamin D, if you are at a risk of vitamin D deficiency, especially during these COVID times, it is always better to take a first reading of vitamin D, your vitamin D level, so that you can take appropriate dosages of vitamin D. There are differences of opinion. Some say everybody is vitamin D deficient, so why do you want to test? Just take. But as I told earlier, when the deficiency is very huge deficiency, it is better to give bolus or high doses to start with, and then go to a maintenance dose. So how often should you do it? If you are leading the same deficiency state, I have had patients who come and say, doctor, I had vitamin D of 4 nanogram per ml. And they had lots of problems, including joint pains, bone pains, diabetes. They had hair loss. A few of them had psoriasis. So these patients, what they told was, when doctors prescribed me vitamin D, I took the course for 3 months, then stopped. There is a question that I asked to everyone: do you drive? If you drive a car, you should know that when the petrol goes into reserve and you fill the tank, it will not run forever. It will not run for life. It will again come to reserve. So if you don't change your lifestyle and expose yourself to sunlight, it is always better to continue on a maintenance dose. There is no course. It is a lifelong course for vitamin D, as well as Dr. Shashidharan told, as well as other nutrients. So having a nutritional balanced diet and leading a lifestyle, healthy lifestyle, is not a course of action. It is a lifelong commitment.
In fact, if you are using only at maintenance dose, you don't have to test at all.
Yes,
but if you are using larger doses in the initial period, not to only in very severe deficiency, use larger doses only in very severe deficiency. Yes. In those cases, you can monitor with vitamin D levels. If you are giving only just maintenance dose up to 2000 units per day, you don't have to monitor at all. You can give indefinitely, but ensure that the patient gets a good lifestyle and diet habits, including sunlight exposure, till everything is corrected.
Yes, yes. Thank you.
I have one question. Dr. Hanish Babu mentioned 10,000 units per day, or even 5,000 units per day. What about the parenteral route of administration, injection vitamin D in these cases?
Usually it is only reserved for very deficient, that is below 5. If the patient comes to increase the levels to a level. For normally insufficient or normal patients, we should not give the parenteral route, because it can the patient can suddenly go into hypercalciuria if the calcium level is also high. So these things we are discussing in the second talk as well.
In fact, injectable vitamin D should be given only in symptomatic severe deficiency, like osteomalacia or severe rickets. Okay. Even the level does not matter if the patient is not symptomatic. Actually, it should be based on severe symptoms like osteomalacia or severe rickets. In those patients where there is an urgency in correction only, we should go for injectable vitamin D. That is usually given in pediatric population. Osteomalacia also you can.
Yes. Any other
questions? Two other questions. One question to already Professor Shashidaran has answered. What other tests we have to do when vitamin D is low? You have already told folic acid and other. Just please answer.
All these are, in fact, that is why I pointed out, because my time was only 15 minutes. That is why I rushed through that. If you have one deficiency, it invariably means all other vitamins are deficient. It's only the tip of the iceberg. That includes sometimes iron, sometimes folic acid, sometimes viridoxine, whatnot. Everything is deficient. So instead of testing all these, you take a detailed dietary history. You will be surprised to find out every day I am taking dietary history. They do not even take protein. There is no protein in the diet. There is no vegetables in the diet. There is no fruits in the diet. And then we are checking vitamin D level. What is the point in doing that? Take a dietary history, find out what is deficient and correct that. And that's the best policy rather than checking all the levels.
Very, very important point by Professor Shashidaran. Taking dietary history is very important for not only for dermatologists, for all specialties. It's even though we can take a little time to see how their dietary. See, there are many dietary fads out there. There are vegans, there are pure vegetarians, there are vegetarians, there are keto diet, that is LCHF. All these things many of these can lead to particular deficiencies. For example, many vegans come and most of them are deficient in vitamin D as well as vitamin B12. Maybe other deficiencies also. So whenever you are going, it is better not to go for dietary fats. But if you to reduce, for example, if to reduce weight, you are going into such things, always take care that you have a balanced diet. And if it is not balanced, take supplements. If you have a balanced diet, there is no need for supplements as such.
One final question, Dr. Hanish Babu, Dr. Safrullah had asked, what's the best time for sunlight exposure? And Asian ethnic origin, how much is the time advised for sunlight exposure?
We know that ultraviolet B rays produce vitamin D in our skin from the sun rays. So it is from the cholesterol derivative, 7-dehydrocholesterol is getting converted to vitamin D, inactive vitamin D actually, by the action of UVB rays. So UVB rays are usually present between 10 to 3, maybe extend up to 4. In the early morning and evening time, there is very little UVB rays. It is more of UVA rays. So we have to suggest patients to go to this. While advising on the time, we have to take care of the skin type of the patient. If it is the fairer type, the type 1 or 2 or even up to 3, they have to expose only very little time. But if it is the brownish or our type of very little means 15 minutes maximum to 20 minutes. That is enough for them. But for us, half an hour to 45 minutes is required. If it is a very dark skin, the studies have pointed out for them to get sufficient amount of vitamin D, they have to expose somewhere between 45 to 1 hour. But this is not required continuously because we know in in the summer, especially during this time, if you are exposed to sunlight, you are bound to get sunstroke or heat stroke. So you have to take care of that also and avoid going out during this period, during the summer. If you are deficient, take a supplement and go intermittently. That is better. And there is also a point
8 to 10 minutes exposure.
How many percentage of skin surface is needed to be exposed to properly. So that
even 5 to 10 minutes exposure,
40% is told. In our new the modern lifestyle, it is very difficult for us to go outside and expose our body. So exposing to your wearing a t-shirt and exposing your whole arm and knickers with exposing to the legs and face will be sufficient. Face, of course, most people wear the sunblock, but that does not, the sunblock actually is, unless you apply like the cricketers do, it is not going to completely stop the UVB rays.
Study in among doctors in UAE 4 or 5 years back, found that many doctors were having low levels of vitamin D3.
Yes.
And another thing, Dr. Hanish Babu, even 10 to 15 minutes, if you can stand in the balcony or outside, that also helps.
That helps, of course, because vitamin D can be taken from 3 sources. One is from the sun, that is the main source, and it should be the main source. Second is from our food. This all we will discuss later, but just mainly the food. The sources of vitamin D in food is comparatively 20 to 30% only we get from food. This is the oily fish we will have, and the milk and milk products which are fortified with vitamin D. And for the vegetarians, very low vitamin D sources. Only thing is the mushrooms that are grown in the sunlight, they may contain little vitamin D. So mainly the fish, the yolk of the egg, liver of beef, and red meats a little amount can give food dietary sources. And plus, of course, the last one is if you are really deficient, take the supplements. There is nothing wrong in taking supplements, but there are many studies who say, note this point, you never become toxic with vitamin D produced from the sunlight. You never become, because there is a controlling, regulating mechanism also. If you have more sunlight, UVB rays, and then the active vitamin D will be inactivated. So only the amount that is required will only be produced by the sun. But when you take a supplement, it is completely different. You may be taking more than what is needed and go into toxic levels. So this you have to, as Dr. Shashi Dharan told, if you are taking higher doses, always better to check routinely, at least 6 months, every 6 months also. Otherwise, there is no need for routine check. And another thing I would like to say is how we developed the different changes according to the latitude of sun. We have the human race have changed, different races, the Caucasians, the black Africans, the brownish Indians, and the East Asian skin. All these things have developed because of the sunlight, because how we absorb sunlight. It is a balancing between not causing skin cancer and balancing between getting sufficient amount of vitamin D. For those with very dark skin, they have to expose for more time, but the more time should not cause cancer in their skin. So that is why their skin is melanocytes are they are actually filtering the harmful rays most of the time. So it's a balancing act.
I'd like to hear from Professor Shashidharan, because there was one slide he showed workers working in the field, like tilling in the field, and even they had vitamin D deficiency. So what do you say, sir? Is it sunlight alone or proper balanced diet, which is more important? Or both are
this is a point which is often overlooked. One should know that sunlight will give vitamin D provided you give the substrate. The substrate is in the diet only. Without a substrate in the diet, most of these workers, if they will be just eating calories only. They do not have even protein in the diet, leave alone vitamin D containing protein. We have only very few vitamin D containing proteins, unless you selectively take them, like egg yolk, mushroom, curd. Better to take curd other than milk. And meat also, most of the meats contain. If you take one of the vitamin D containing food, along with that, at least cholesterol should be there. That is a substrate for vitamin D synthesis. If you are not taking proper diet and getting sunlight exposure alone, you will not get any vitamin D. So it is important to have proper diet and then sunlight exposure. These two are important. The substrate is from the diet only.
That is an important
Final
point.
question, since today's topic is COVID-19 and vitamin D. Then one viewer had asked, will adequate vitamin D prevent COVID-19? Dr. Hanish already touched upon the subject, but still, as a concluding remark, Dr. Hanish.
See, vitamin D is not the only thing, as we have been telling, the only factor. But being an important factor in our immunity and keeping our normal immune response to any invading organism, we have to see that vitamin D is appropriate. As we know, it is not only vitamin D, we have to have all other nutrients in normal range, and also lead a healthy lifestyle, and also manage our comorbidities well. All these taken together will definitely help. Yes.
Thank you, Dr. Hanish. Many of the chats I am getting messages that they are all looking forward to your 2 more talks.
Yeah.
And I'm sure you will touch upon pediatrics also, this Causality type disease and all, whether vitamin D is important in that also. I'm sure you will touch upon that.
Those things will be covered in the third part of the talk.
Yeah, thank you.
Why I am going into details of all the things about vitamin D is it's not like any other vitamin or hormone. It is the only vitamin which is, as we have already seen, it is produced in our body. This is the survival mechanism of our body. So it is very important, one. Second, it is unlike any other hormone. It can also be taken and it is produced in our body. So it stands high above all other nutrients and minerals and vitamins. So this is what we have to understand, and instead of just pushing it aside as an optimum, as just a supplement, optional supplement, we have to understand that it is a cellular necessity. These details we will go into next talk. Please do attend. And I'm sorry for the initial hiccups because we could not go online on the Facebook Live. I don't know what happened. Next time we will share the Zoom link only, and we can all meet here. And then later I will upload for the others whom you would like to go through this talk. Your other colleagues, you can share from the Facebook page.